Hi everyone, this is Esther from Central and Eastern Sydney PHN. Thanks for joining me today online. Today I'll be providing you with an overview of the Mental Health and AOD Action Plan. I'd like to start off with an acknowledgement of country. Central and Eastern Sydney PHN acknowledges the Aboriginal and Torres Strait Islander peoples of this nation. We acknowledge the traditional custodians and sovereign people of the land across which we work. We recognise their continuing connection to land, water and community, and I'd like to pay my respects to elders past, present and emerging. The Mental Health and AOD Action Plan is the outcome of the collaborative work of the members and stakeholders involved in the Mental Health and AOD Working Party that met throughout 2019. And the purpose of this presentation is to outline the drafted action plan and the proposed action strategies, as well as update you on progress made towards these particular actions. We're seeking feedback and endorsement of this action plan. I'd like to acknowledge the fantastic work of all those who contributed to the plan. Firstly, a bit of a recap. So Central and Eastern Sydney PHN identify that people with co-occurring AOD and mental health conditions are a priority in our region and can experience barriers to effective service provision. To inform how best to address this priority area, we funded the Centre of Research Excellence in Mental Health and Substance Use, or CREMS, now the Matilda Centre, to undertake a scoping exercise to evaluate the practices and support needs of healthcare workers in the region who are working with clients with co-occurring needs. The scoping exercise was undertaken to improve understanding of these issues and provide recommendations for workforce development and capacity building. Links to this report and others mentioned within the presentation are linked at the end of the PowerPoint. So in order to respond to the report and the recommendations, CESPHN convened a working party of members with a range of skills and expertise across mental health, AOD, community, allied health, general practice, as well as people with a lived experience of mental health and alcohol and other drug issues. The working party formed 4 small groups to focus on key areas of workforce development and create an action plan to meet report recommendations. So I'll present now what was developed in these small groups, and you'll notice that some strategies address multiple recommendations. So on this slide, you can see how the recommendations from the Matilda Centre were grouped into the 4 focus areas by the working party. And I'll run through each of the group recommendations and proposed strategies from each. So Group 1 looked at integrated models of care, with the 2 recommendations being, firstly, 1, the development and pilot testing of innovative services and enhancement of existing services to address areas of unmet need. And secondly, the development and pilot testing of a model of coordinated care. So the strategies proposed by the group were to, firstly, identify the elements of effective coordinated care, and the group reviewed literature and drew on experience to identify the elements of effective models. They're referred to, for example, the evidence check review of effective models of care for comorbid mental illness and illicit substance use. The second strategy was to identify services within the CESPHN region that included these elements of effective models of coordinated care. They consulted with working party members, CESPHN advisory committees and councils, as well as local services delivering coordinated care. A model that was discussed as an ideal example was the Inner City Youth at Risk, or ICYA model, which previously operated in the inner city of Sydney as a partnership led by South Eastern Sydney LHD, together with 21 government and non-government organisations to target and respond to young people experiencing or at risk of homelessness. Some of the key features of this model include, firstly, coordinated case management. Now the model strengthens the quality of case management provided by partner organisations. It's not providing case management directly. ICYA provides a coordinating role across service provision agencies rather than duplicating supports provided by participating agencies. And this was important for steering the project and managing logistics of regular meetings. So secondly, steering meetings. So these allow for joint planning and problem solving, the sharing of expertise and dividing up the care coordination role with a lead agency for each client. Thirdly, it also includes brokerage funding. So a small amount of funds for goods and services to clients that would otherwise be unavailable. For things such as transport and medication. This can significantly improve care and outcomes for individuals. As well as within this model, the sector development activities related to the program, which would often come about in partnership with other organisations. And you can find out more about the key principles, steps and processes in replicating this model in the report linked at the end of the presentation. The next strategies would be to implement the model through a pilot project and also expanding this if proving to be successful. This would involve determining the pilot scope, so the location, target population, services to be involved and costs. And the working group had the idea that this ICYA model could be trialled to support people with co-occurring mental health and AOD needs within the King's Cross inner city region. Implementation would involve building an understanding of the enablers and motivators to participate, then the recruitment of clients and services, establishing formal agreements, identifying an independent evaluator, as well as determining an evaluation framework. So this step requires contract development, funding for the coordinator position, as well as funds for brokerage and evaluation. The second part of this strategy is, of course, promoting and expanding the provision of effective coordinated care. And this is about sustaining and embedding change beyond the project period. This could include showcasing the project, launching and disseminating an evaluation and promoting the model at relevant conferences, for example. And outcomes could be shared with local and national mental health and AOD PHN networks, peak bodies and other funders. Group 2. So the smaller working group number 2 looked at training and resources to support the workforce, and they addressed 2 recommendations from the scoping report. Those being, firstly, 1, the provision of education and training opportunities for healthcare workers in mental health and AOD comorbidity, and 2, improved access to up-to-date evidence-based information on mental health and AOD use, and the development of evidence-based resources. The strategies suggested to meet the 2 training and resources recommendations are listed here, so there are 6 of them. The first one is embed workforce development training criteria within service provider contracts. So this involved the inclusion of specific clauses within CESPHN contracts that require funded workers to engage in training that supports working with co-occurring needs, specifically the comorbidity guidelines and online training developed by the Matilda Centre. And as of this financial year, CESPHN contracts now include a standard minimum requirement for funded staff in commissioned mental health and alcohol and other drug contracts to complete the training on comorbidity guidelines to support the development of skills in working with clients with co-occurring mental health and AOD needs. On this slide, you can see the highlighted areas are the particular clause that's been included within the contracts. You can feel free to pause this slide and have a read through. The second strategy is focused on GPs and seeks to investigate current quality improvement incentives and existing GP education. So there's still investigation and further development to be done on this strategy. But here you'll see some of the quality improvement incentives within GP practice. One of which is the Practice Incentives Program Quality Improvement Incentive, or QIPIP. This is a Department of Health payment to general practices for activities that support continuous quality improvement in patient outcomes and the delivery of best practice care. So general practices enrolled in the QIPIP incentive firstly commit to implementing continuous quality improvement activities that support them in their role of managing their patients' health. And they also commit to submitting nationally consistent de-identified general practice data against 10 key improvement measures that contribute to local, regional and national health outcomes. So from these 10 improvement measures that are across health, there is the following measure that asks within the data, proportion of patients with an alcohol consumption status. Now, mental health minimum data isn't included within this 10 set. And for a full list and for more information, you can go to our CESPHN website or refer to the references at the end of this presentation. So the CESPHN Practice Support Team can assist practices with their accreditation, the Practice Incentives Program and quality improvement, as well as data collection and extraction and utilisation of these tools. So the working group felt there may be some alignment between QIPIP and Mental Health and AOD Action Plan. These domains promote knowledge and skill in supporting mental health and AOD needs of patients, and any new education should be considered alongside QIPIP. Following on around GP education, so the Australian government has announced a no-cost education package and training grants for GPs to improve support and increase resources available to them to treat drug and alcohol use in patients. And funding's been provided to both the Royal Australian College of General Practitioners, RACGP, and the Australian College of Rural and Remote Medicine, or ACRM, to administer the training package. There are various levels of skills training, and the PHN have a role in promoting the training, which we're doing through our website and communications, as well as the GP Liaison and Other Drugs, or GLAD project funded by CESPHN. Within the GLAD project, they're well placed to promote this training and are doing so with GPs that they engage with through the project. And although this training package is promoted as alcohol and other drugs training, it recognises the high prevalence of co-occurring needs and includes content in this area. The package includes access to weekly project echo hubs, so where GPs can bring de-identified patient examples and ask personalised questions about complex care. And in relation to mental health CPD offerings, there are a few. So the GP Psychiatry Support Line has webinars which GPs can watch for CPD points. There's free online training for GPs in youth mental health provided by Headspace, and Emerging Minds offer education on child mental health for GPs too. And I guess Central and Eastern Sydney PHN look to continue to identify and promote available training and education, as well as identify gaps and opportunities. The third strategy is to update the CESPHN web pages to support engagement in education and training relating to co-occurring mental health and AOD. This is an example of the website that's looking to be up to date. So by keeping our website up to date and relevant, we can improve access to up-to-date evidence-based info on mental health and AOD use. At the moment, we're building a workforce and training page on the mental health pages, which will be duplicated for the AOD sections. And it will list training and workforce development offerings and resources. And this particular strategy around developing the website is really linked to other recommendations too to follow. Regular communications was the fourth strategy proposed. CESPHN have convened a communications working group looking at joint promotion and communications across the CESPHN clinical streams, which includes youth mental health, severe to low to moderate mental health, suicide prevention, Aboriginal health and wellbeing, and drug and alcohol. This is a fantastic opportunity to synthesise communications across Commission service providers, local allied health providers and GPs that we're in touch with. So comms ideas include the development of a joint newsletter and particular editions, website updates, practical tips, client stories, and peer workforce experiences, for example. The fifth strategy is determining key training themes. And this next strategy is around training themes and the criteria required for endorsed training and the specific areas of practice to target. For example, cultural competency or stigma and discrimination training. There have been some really fantastic developments in this space since the proposal of this strategy, including the development of a workforce development capability framework by NADA. This framework provides a common foundation for full range of workforce development activities, such as workforce planning, role design and description, recruitment and selection, performance management, professional development and career planning. And also there are resources on position descriptions across AOD workers, but also caseworkers, counsellors, psychologists and registered nurses, for example. Also, the NCETA recently released their workforce survey results, which outline national workforce development needs for AOD sector. So the smaller working group discussed how training is most effective if it's specifically tailored to different practitioners and their specific role in supporting those experiencing mental health and AOD issues. Also, rather than only focusing on skills and knowledge in mental health and AOD, training should also emphasise the importance of practitioner attributes. For example, respecting the individual, how to engage in open discussions, language to use, and the importance of reducing stigma and judgment. The working group talked in depth about promoting and supporting engagement in training that can be applied across multiple practitioner types, such as suicide prevention training. Now, the final strategy in relation to education and training was investigating and promoting opportunities around workshops and communities of practice. So, what's available? Well, New South Wales Health have established clinical communities of practice to support the New South Wales Health response to COVID-19 within both mental health and AOD. Additionally, the Matilda Centre's Train the Trainer event, which is currently on hold due to COVID-19 restrictions, aims to train the workforce in being able to effectively train others on the comorbidity guidelines. And this can support ongoing workforce development in the space, as well as having trainers across the sector. There are other mental health related community of practices too, including Network Mind Out, supporting professional development of mental health and suicide prevention sectors to practice and implement strategies that support inclusive and accessible services to LGBTI people and communities. Also, the Wayback Support Service offers a community of practice for staff, and that's through Beyond Blue. Group 3. So Group 3 looked at clinical supervision, and the recommendation being that support for workforce requires the provision and ongoing support of clinical supervision in co-occurring mental health and AOD. So here are the 6 strategies in relation to clinical supervision. The first one was similar to the training strategy previously discussed, and that's developing the CESPHN website. Now, this could include the following: a local directory of clinical supervision providers, which are endorsed, for example, worker success stories, links to further resources and training. Some of the steps involved in this strategy, which will be similar to the training and resources strategy, are around really researching and consulting with relevant stakeholders to collate up-to-date information for the website and ensure that there's ongoing updates and reviews on this. The second strategy was around including more information on clinical supervision within the Matilda Centre's comorbidity guidelines. The guidelines currently do have information on clinical supervision. There could be information for workers on how to engage meaningfully with clinical supervision and some key considerations for the process to ensure that they're getting the most out of their experience. CESPHN recently provided this feedback into the revision of the comorbidity guidelines on this particular idea at the event that happened earlier on in the year. Strategies 3 and 4. So at the moment, we work together with providers to understand their program costs and budgets. As commissioners, we try to cover the real costs where possible, but recognise that this is not always the case and there are sometimes overheads. Clinical supervision is an expectation for those providing mental health and AOD treatment to clients, and this is included as a contractual clause within those CESPHN contracts. The next strategy is that the workforce learns from one another to improve outcomes for clients with co-occurring mental health and AOD needs. For example, local health district mental health and drug and alcohol staff could attend joint supervision or meet regularly for reflective practice and look at joint case coordination. This strategy is linked to the idea of an ongoing community of practice to support workers to connect with one another in an environment where they're learning from one another and in cases doing joint case care coordination. The final strategy is that local staff are supported to access clinical supervision training to become clinical supervisors. So there are the supervisor workshops for clinical supervisors offered to local workforce so that they can upskill with initial and masterclasses offered. So support for this initiative by improving access and removing the financial barrier could be considered. Now, the final recommendation is the provision of specialised training scholarships and subsidised placements in AOD and mental health services. Next year, CESPHN will be funding double whammy, drug and alcohol and mental health training within the region. There are also opportunities for workers to engage in the Matilda Centre's Train the Trainer for learning the ins and outs of the comorbidity guidelines and becoming confident to support others in this. Here listed are the proposed strategies. Again, training and scholarship opportunities can be promoted via our website and comms channels, as well as through peak bodies. The second strategy is exploring the viability of a reciprocal rotations project. And this means identifying local projects across mental health and AOD that may foster learning through co-facilitation of groups. For example, across the region, there are recovery-focused groups such as Smart Recovery, AOD Recovery. There are Flourish groups, suicide prevention support, family drug support groups, generalised anxiety disorder recovery groups. There's also youth smart recovery, just to name a few. There could be opportunity for cross-facilitation of these groups, and we'd like to gauge feedback from stakeholders about this idea, and organisations could submit their proposal for co-occurring needs related initiatives to CESPHN. The third strategy is called randomised copy trials. So randomised copy trials, or RCTs, are an innovation originating in the UK in 2013. They're used to connect people in an organisation at random and give them time to meet, to have a coffee and talk about whatever they wish. RCTs, well, they're an attempt to build meaningful connections that can lead to real change. It's based off the Victorian project within the Dual Diagnosis Project from the Hume Border region, which is linked there for more information on this project. Just to give you an idea, this project is designed to pair AOD with mental health workers or vice versa. There's a really small buy-in per organisation. Workers feedback one new thing they've learned in the course of the coffee. And the project is based on the idea that effective responses to people with dual diagnosis are often really dependent on developed cross-sector relationships that facilitate navigatable treatment pathways, case conferencing and cross-sector secondary consultations. I mean, within mental health and AOD, workers work in pressured environments that allow little time often for developing and maintaining cross-sector relationships, and often workers only come together around really highly charged presentations of people in crisis situations. So this is building the opportunity for AOD and mental health workers to meet in more informal, reflective circumstances, and in turn, it could likely contribute to improved cross-sector relationships and understandings, treatment pathways, and better outcomes for people. It also is intended to break down conceptions around the complexity of practicing in the opposite sector to a person's current role, to build confidence to work with clients who have co-occurring needs and encourage pursuit of professional development in this area. So, I mean, how could this project work? Well, we could look to identify interested parties within the CESPHN region. We could present the RCD project at local networking events and request an EOI from interested people or orgs. We would then collate the EOIs, matching workers based on their sector and what their learning goals are. A simple email introduction so the pairs can arrange a meeting, and a small amount of funding for a coffee. The workers are then encouraged to have a relaxed conversation about whatever they choose, and workers then feedback one new thing they've learned at the meeting. These learnings are then collated and shared. Like I said, you can find out more information about the trial that ran within the Hume border region in the references of this presentation or at the link below. So I'd like to once again say thank you and acknowledge the working party for their time, commitment and contributions for the plan. The members are listed here. So we would really like to hear from you. You're welcome to provide feedback on the plan via email, directly or anonymously through the link. We can also arrange a meeting either by phone or in person to get some feedback, or if you have any questions. Please get in touch with any one of us from the team. Otherwise, we ask for you to confirm that you endorse the plan and that you're happy for the implementation to proceed. But yes, thank you. That concludes the presentation today. Thanks for your time once again for tuning in. We're really looking forward to hearing from you all.